Good morning, I'm Teresa Perra, resident in general surgery at the University of Sassari. It's a pleasure to participate. I would like to thank you for accepting this work for poster presentation and for giving me the opportunity to present our work in this conference. I talk about a work that I realized with Professor Alberto Porcu about the intraoperative assessment of tissue oxygenation for prediction of bile leakage in liver resection with hepatic jejunostomy for cholangiocarcinoma. Cholangiocarcinoma is the second most common primary liver cancer, and surgery is the only potentially curative treatment for patients with resectable disease. Bile leakage is an important complication following liver resection with hepatic jejunostomy for cholangiocarcinoma, causing an increase of morbidity and mortality. Many factors can affect the occurrence of anastomotic leak. Risk factor for postoperative leakage can be an increased body mass index, preoperative endoscopic biliary drainage, and anastomosis on segmental bile ducts. Tissue oxygenation at the anastomotic site can also influence the occurrence of anastomotic leak. The aim of our study was to evaluate if a non-invasive, easy-to-use and cheap method as an intraoperative tissue oximetry could be used to assess tissue perfusion before performing anastomosis and predict anastomotic leak. A literature search was performed using the PubMed database and a reference list of relevant articles to identify papers about the use of intraoperative tissue oximetry in hepatobiliary surgery. What are the results? There is a lack in literature about this topic. There are no studies that present that have evaluated the feasibility of intraoperative tissue oximetry in hepatobiliary and pancreatic surgery. Some studies assess its utility in other kinds of surgery. Tissue oxygenation seems to be potentially useful to predict anastomotic leakage after colorectal surgery. A prospective study by Salus-Jarvi et al. Conducted on 422 patients undergoing elective left-sided colorectal surgery showed that low intraoperative colonic oxygen saturation are associated with the occurrence of anastomotic leak. Despite its limit, the method seems to be useful in assessing anastomotic viability. Conversely, no association was found in patients undergoing Ivor-Lewis esophagectomy. A prospective clinical trial by Adesumili et al. Conducted over a 2-year period observed no significant association between intraoperative tissue oxygenation at the anastomotic site and subsequent anastomotic leak or stricture formation among patients undergoing Ivor-Lewis esophagectomy. The assessment of intestinal perfusion can reduce the risk of anastomotic leakage in gastrointestinal surgery. A study by Sarves et al. Tested the efficacy of a device they designed to detect early tissue hypoxia in stomach, intestine, and kidneys in anesthetized rats and stewing. They constructed, validated, and successfully tested a novel wireless pulse oximeter capable of detecting intraoperative tissue hypoxia in open and endoscopic surgery. They showed that this device could aid surgeons in detecting anastomotic vascular compromise and facilitate choosing an ideal site for bowel anastomosis by targeting well-perfused tissue with optimal healing capacity. In 2014, Andersen and Guggerner performed a review of the literature that showed 3 different methods to evaluate the intestinal perfusion to reduce the risk of anastomotic leakage in the gastrointestinal tract: oxygen saturation, fluorescence-guided surgery, and laser Doppler fluximetry. None of them have been implemented in surgical everyday. They underline that there is a need for more research in this field before any of the methods are ready to be used in the surgical standard procedure. So there is a lack in literature about the use of intraoperative tissue oximetry in hepatobiliary surgery. One potential contributing factor to incidence of anastomotic leak is variability of tissue oxygenation at an anastomotic site. Real-time intraoperative detection of tissue hypoxia could be very useful. When surgeons perform an anastomosis, they minimize tension on it and evaluate it for good perfusion, usually by visual inspection only. But visual inspection is a subjective way to evaluate perfusion compromise. There can be poor perfusion without evident physical changes. An intraoperative tissue oximetry could help surgeons in detecting anastomotic vascular compromise and choose the most suitable site to perform anastomosis. Further research is needed in this field. Moreover, with the increasing development of laparoscopic and robotic surgery, where there is no tactile or visual feedback of anastomotic tension or tissue oxygenation, an objective real-time reading of tissue oxygenation at the point of interest for surgeons could be useful. It could be easily incorporated into robotic fingers to measure tissue oxygenation. Other methods as fluorescent guide surgery and laser Doppler fluximetry should be considered and compared. They too can be used to help identifying poor perfusion objectively. Thank you for your attention.